What happens when a close protection officer faces a medical crisis, but it's not a bullet wound? We already talked about tactical medicine here on the podcast. We talked about TCCC, we talked about TECC, but today we want to talk about heart attacks and asthma, what also can happen to our clients. So thank you very much, Michael, for being here. If you would like to introduce yourself.
Hey, Inga, thanks for having me. So my name is Michael Gerges. I'm a board-trained emergency medicine physician here in the United States. I've done emergency medicine here in California for 22 years. I also have a background in law enforcement. When I was going through medical school, I started sheriff's training down here in the United States, and I've been a reserve deputy in California with the sheriff's department. Most of my time was doing air rescue. So I've been on an aviation unit doing medical rescues, hoist rescues out through here in San Bernardino County, which is a large area. I also do event medicine, NASCAR, big racing here. I know you've got a large viewership in other countries, so I'm trying to explain. But sports medicine, and in the last 5 years, I've got introduced into the world of executive protection, CPO, and I've been kind of helping integrate medicine, either integrating medical folks into the security world or kind of teaching security folks a little more than the basic TECC medicine so that they can use those skills while they're working.
Yeah, your background definitely is very impressive and very diverse. So we already talked a little bit about TECC, so we won't talk about that much. But what do you think, what other skills should a close protection officer have besides TECC?
Yeah, so I think the baseline for all executive protection professionals is going to be your basic life support, including CPR, how to use the AED, basic airway support, with which you'll learn in CPR class, stop the bleed training. So if you want to take a TECC or TCCC, or just even in the United States, we have a stop the bleed course, then I think that is fine. But basically how to use a tourniquet, how to place chest seals, packing wounds. Very unlikely you're going to pack wounds in kind of domestic injuries. And I think that's the basic. That's what I would expect anybody to do, because those are all skill sets. You don't have to have that higher level of medical knowledge to know. Once you start getting folks, we would love if you knew about chest pain and what an EKG read, that just becomes too complicated for the everyday typical. But anybody who calls himself a security agent or an executive protection agent or a CPO, they have to have those skills. I mean, those are skills that you can at least get the basics down in an 8-hour period. And then obviously with practice, because of the perishable skills that they are, practice even once a month, even 20 minutes a month is something that if you continue to do, then it makes it work a lot better in your mind, so that you can use them when the stress of that incident occurs. You're not just going blank.
Yeah. No, I totally agree. I think everyone should do the TECC, but like you said, everyone also should do like basic life support. I think it's also included in the FRAC free, right?
Yeah, so I'm not too familiar with the FRAC free. I mean, I think that's a European thing.
Okay.
So, but yeah, I would assume that, basic life support is basically what it's called. It's very basic.
Yes.
And then you've got kind of advanced cardiac and advanced life support and advanced trauma life support, and that becomes much more complicated, which I wouldn't expect an everyday, security professional to know, nor should they. It's very advanced.
What equivalent do you have in the US to you said FRAC free is like a European thing, but what basic life support course would you say is typical to do in the US?
We have like American Heart Association, just the, CPR AED course, and FRAC free may be a little more encompassing of a little more medical. I don't know exactly what they're trained to do. Those who want to increase their medical knowledge can go through an EMT basic course, which is a course that's usually around a month. I think it's about 150 to 200 hours of training, ambulance ride outs, and then they get nationally certified and then get licensed locally where they're going to be working and then work under, an ambulance company or an event medicine company or some security companies. I'm medical director for some security companies or some corporate companies that have security components to it, where I've become medical director, and then I kind of oversee the operations and all the EMTs and medics that work under, my umbrella, to perform their scope of practice, with continuing education, training, medication, ordering, and making sure that they're well packed and ready to go for, operations.
Okay, great. So yeah, from your experience working on events and also in the close protection sector, what is more often, like trauma or non-trauma events?
Yeah. I think domestically, in corporate and, private family office security, it's going to be medical issues. Obviously, if you're out boating, yeah, and you're doing kind of dangerous climbs and things like that, then yeah, so maybe some trauma. But for everyday life, it's going to be medical, right? You've got clients with family that may be in tow. You've got clients who may be just doing corporate events, and there's 500 people in a banquet hall for some meeting. Someone's going to have a medical emergency. And if it's a traumatic emergency, God forbid, a shooting or something like that, it's someone rolled their ankle or anything. That's not rocket science. Stay off of it. Go get an X-ray. Go to the urgent care. But medical emergencies are going to be, the main issues. Your banquet hall with allergic reaction to, whatever nut allergy, or shellfish allergy are very common. Or, if you've got an older population, the chest pains, the shortness of breath, the shortness of breath secondary to fatigue from congestive heart failure, because they have to just walk, a long distance to get to the event. So the medical, but that's where that becomes very difficult to train every security folk, because it's pharmacology, pathophysiology. It's really hard. You can't teach that in an 8-hour course. You can kind of train for it over time if you've got a medical program and you're able to hone in those pathologies based on your principal's profile. But that you need a whole medical program for that. And my thought is the easiest way to implement that medical program is to implement med direction and then, hire folks on the security team. And it doesn't have to be the majority. It could be a small, subset of the security team itself. Is you're hiring a paramedic who's got the training, the ability to kind of perform those medical interventions if needed, and then also train those around them on downtime, on operations or, training days.
Okay, yeah, I agree that especially if you work on events, that it's very hard to train every single event security like medically, but also like you're saying, an 8-hour course should be a minimum even for someone working at an event, because you also there see dehydration, you see people fainting, for example, because standing too long, or yeah, like you're saying, older folks who have a heart attack or so. So I think, like you're saying, basic life support like CPR or something, everyone who works in security should know. And yeah, like you're saying, if you have a medical director, that's of course perfect to teach the people. But I think especially in close protection, if you want to call yourself close protection officer, you should have a little bit more training than basic CPR and yeah, 8 hours of education, I think.
Absolutely. 100% agree with you.
Okay. 1 second. Yes, we're talking about paramedics, or you have been talking about paramedics, and I feel like there are a lot of people running around in the security industry calling themselves a medic, but yeah, what would you define a medic or paramedic?
Yeah, so I'll speak for us here in the United States. It's A paramedic is someone who went through paramedic, it's called EMT paramedic training. It's a minimum of 1 year. I believe it's around 2,000 hours of training, who is nationally recognized and locally recognized by, our state's licensing board as a paramedic that's gone through paramedic training school, who's been certified through National Registry of EMT, and then who becomes licensed locally and then works for a company with medical oversight, where their scope of practice is either determined by the state or the local entity that they're working in, and then also their med direction. Yeah, I
Okay.
mean, there's a lot of people that just will call the EMT the medic, and it's, I don't think there's anything nefarious that they're trying to do by calling themselves the medic. I just think most lay people who aren't in the medical field don't understand the difference of what an EMT basic is, what their scope of practice is compared to, an EMT paramedic or a paramedic. And they just think of medical folks as medics.
Yeah.
So, it's, but I mean, there's a clear distinction once you kind of get into what a medic can do, depending on if they're EMT basic, advanced, paramedic, and that scope is very, very large and varying. So,
Yeah, no, I totally agree. Because I think it's good that more and more people are picking up the medical side of the security business. But yeah, just because you did a 1 week course, you can't call yourself a
yeah,
medic. So if you look at real medical professionals like paramedics who are working in that field, there's a lot more hours you need to do, and also a lot of other stuff besides stop the bleed that you need to be aware of to actually be able to call yourself paramedic. So I
right.
totally agree with that.
Yeah. And there's other things in the security world that, people call themselves special forces and things like that. And I think that's a little different because I think they understand what that is, but I think it's more of an innocent, just I'm a medic, and they just don't understand it.
Yeah.
Unless you're a medic or an EMT calling yourself a medic, then I think you kind of know what you're selling something that you're not, and then that's more of an issue.
Yeah. No, totally agree. Maybe one question. What do you think is easier, to train a paramedic in close protection or train a close protection officer to become a paramedic?
Yeah, I think your first statement is correct. I think taking someone who's a paramedic, who's worked in the field, who's got that experience, and then teaching them close protection is a lot easier than teaching a close protection officer, EP officer, to become a paramedic. Because the paramedic training is 1,000 hours plus, a year plus. You and I see this in the industry where people go into EMT school and then they do maybe one ambulance ride out, and then they're now EMTs on the team, and it's so dangerous because you just don't. You have to have that field experience. You've got to have that hands on. And if you just think that I mean, prime example, when I went to medical school, I didn't know anything coming out of 4 years of medical school. When I got into my residency and started doing emergency medicine, that's where the actual knowledge came. You started seeing the one asthma. You started to realize, oh, I missed hearing this or seeing this. I didn't see the personal breathing. And then as you see more and more cases, it just becomes in your mind second nature, shorter breath, possible audible wheezing, auscultation of audible wheezing, maybe pursed lip breathing. They're now tripoding, and you start to just see with patterns kind of what you've read in the books forever, but it doesn't really make sense until you see it multiple times again. Prime example, kidney stones. I can tell someone has a kidney stone from across the room just because they look like they're in pain. They look like they're dying. They can't sit still. And you could just tell, and it's that flank pain to the groin or into the testicle or whatever their symptoms are. But it's a instant diagnosis. You could read that in a book, but until you've seen it a few times, you're just never going to know it well. So that's, I think, the main issue. And it's hard. Not every single paramedic can be a close protection officer. There's some innate skills in some folks. Just situational awareness and things like that that not everybody has. And you just want to kind of pick those guys who may have had an interest in security work and then put them into, the security training. I mean, most security training you can get done in 5, 10 days, 15 days. And then obviously you start to learn operations as you join a team and as you learn how your team works. So, yeah, I mean, I've been asked that a lot, and I've actually thought about that a lot. And I think it's just a lot easier to come in from the medical side than it is to train the medical side.
Yeah, I 100% agree with you in that case as well, because maybe small anecdote, I've been on LinkedIn and someone was looking for a close protection officer for like, I think it was like an Arctic X-Course or something. And I wrote under it, mate, you don't need you don't need security, you need a nurse. If something happens up there, you definitely need a nurse, right? And the security industry, they came at me and said, no, a nurse doesn't know the security industry. And said, well, then tell her how to shoot. Like you said, you can go on one week course, give her a rifle, and then she can shoot ice bears or whatever the task is up there. But if something happens in like a remote location, you don't need security. You need someone who can treat you right and treat you well. And like you're saying, like kidney stones, for example, no one who did a TCCC, who did a 1 week course of medical whatever, cannot see that. So I think that's very important knowledge, which is also very useful in the security industry. Of course, like you're saying, not every nurse, not every paramedic can become security trained. You also need a certain mindset, but I think it's way easier. Of course, you can do security training in 5 weeks and in 5 days, but you can also go on a 5-week course, for example, and even then what you need to put into is way less than if you say, okay, now me as a security professional wants to become a paramedic and now I go to school for 1 year or so. So right. I also 100% agree on that topic with you.
Yeah, no, absolutely. I mean, if you're going on an Arctic expedition, I mean, what are you securing? What are you securing? I mean, you're probably going to be out in the middle of nowhere by yourselves, and then if you're spending that much money on an Arctic expedition, why don't you have a security professional and a nurse or a paramedic or, someone who can at least provide interventions with telemedicine support, back in the States or Europe or, wherever your home base is going to be. Yeah, I think the big thing is just kind of educating security folks, especially the CSOs and the higher ups. I think there's a lot of comfort of, we're not really traveling abroad that much. We're here locally in the States until you need to call 911 and you get a dial tone that they're busy or you can't get a hold of anybody or transport time scene times are going to be 15, 20 minutes away. And you've got your client that's worth, $30 billion languishing in front of you with a bunch of security folks standing over him going, medics will be here soon, so yeah, I think they don't see it until something bad happens. And then obviously everybody starts to want to ramp up, either increase security or implementing medical into their security or bringing folks in to help with security and medical and security. So, I think it's just an education piece. And sometimes it takes something bad to happen before people start to wake up. And even then, sometimes they just wake up for 6 months and then kind of revert back to their old ways. So, I mean, it's just human nature. There's nothing you could do. I don't push medical on anybody. I just try to educate, teach. I'll get folks that will want me to help their teams, maybe temporarily, maybe long term. And I don't try to sell anything. I don't need to sell anything. I'm very comfortable, in my life situation now where it's like, I'm going to work with teams that want to work with me and don't see me as like, the check mark that they have. And then just, I've worked with teams where I felt that and I'm like, this is not for us. You guys can, find someone else who's just willing to do the check mark, but I actually need you guys to take it serious if we're going to implement something real. So.
Yeah, no, that's great. And I think I can also feel the spirit that you have, that you really want to work medically with the team. So like you're saying, checking boxes is not helping anyone. If something goes down, like you said in the example, if we need to call the ambulance and they need 20 minutes, and let's say the CPOs who have like a tech or TECC course and maybe even EMT, what can they actually legally do, and where are the limits of what they can provide with the client with?
Yeah, I mean, so for non-medical folks, I mean, that have, FREC or TECC, I mean, they can do basically up to their training. I mean, you could, for, something medical, you're not really licensed. So, I mean, you can't start doing medical procedures. Like if you've been taught how to put an IV in and start fluids and things like that, and you start putting IV fluids and giving medications and you're not, a paramedic, I mean, then you run the risk of being prosecuted for basically practicing medicine without a license. So, you have to be careful, but, typical CPR, putting band-aids on folks, tourniquets, cleaning wounds, patching wounds. I mean, you don't have to be a medic to, if you notice that someone's ankle is swollen, it may be broken, it may be sprained, to help put a splint on them and wrap it just to immobilize it so they can get to an urgent care and emergency department. What the bad thing is when you know that you're not supposed to do anything, when you know you're a paramedic or an EMT, and I see this a lot, and you're on a security team, and you're may or may not be licensed in the state, but you're not working under medical direction or medical authority. You're not working under a third party company that has a med director, or event medicine company that has a med director and direction, and you start performing EMT skills here in the United States, that is illegal. And very few people are going to give you any leeway because they know you went through training. You know you're supposed to have med direction. You're now just doing this because you're hoping nothing bad happens, and you don't want to deal with having to work under a doctor. And now you're playing with fire. That becomes the real issue. They will yank your license, and they will fine you or give you some jail time depending on how bad you screw up. If something goes sideways while you're performing, that medical scope. So, I see it a lot, where I've even had teams say, "Oh yeah, we work under Good Samaritan. We have the Good Samaritan law here in the United States." And I'm like, well, it's not really Good Samaritan. I mean, you're now being hired as a security professional. You're carrying medical kit other than just your basic life support, AED, CPR, mask, things like that, and you're performing procedures for hire. That's no longer Good Samaritan, and you're no longer either licensed or under medical direction. So that becomes an issue. But I think they just play the odds, and they just try to get away with what they can. And some don't understand maybe that they need medical direction because they went through a quick EMT school and they never really worked in the real world, and they just don't know, or they're just playing their odds. So, you can only educate. And if something bad happens, it's like, you just have to deal with the consequences.
Yeah, okay. Yeah, I think it's very equal to what we have in Europe as well. Yeah, of course, like you're saying, we can do what we're trained in. I'm not a medical professional, so I guess whatever I'm doing, I would never get the idea of putting IV line on someone because, that's not my scope of training. But from what I understood, that if you have a security team which also has a medic, that they should have medical director, because otherwise the medic, I don't want to say he's useless, he still can do a lot of stuff, but not the stuff that he's trained in if he doesn't have medical direction, right?
Yes, I mean, when you think about it, a paramedic knows what he can do, and they can do it. Having a medical director is not like, oh, this is now your skills are, worth something. It's just the way the system is set up. They just don't want a bunch of folks who, let's say, were a medic 15 years ago, still hold the certification because they've continued to do continuing education, and now just go out in the field and say, I'm a medic, and nobody's actually checked their skills in the last 15 years. So it's to prevent that. It's to make sure that guys aren't doing more than, or selling more than they can sell. It's just more of a protection, So I think it's the right thing to do, is just, and you want to get into a skill set where you don't have to, answer to anybody. You become, sometimes nurse practitioners can provide on their own, or some states allow PAs to provide on their own, then, go into that, that direction. But It's just a profession where you just need that oversight and, review of research and review of protocols, new protocol, update protocols. So it's a system that works. I just don't think a lot of people understand it.
Yeah. No, I mean, it totally makes sense, and you need to work into the limits of the system that you're in. Yeah, and if we're talking about buying stuff, selling stuff, what about kit? So what would you tell someone in your close protection team to have in their kit, I would say?
Yeah, so I mean, they call it IFAKs, personal kits, things like that. I mean, I think a tourniquet is always good. Pressure dressings are always good. I mean, my kit's different, but you're basically carrying the TECC materials that you would need based on your training, which is mostly trauma, right? I mean, it's all trauma. What do we say? I mean, obviously, if you're doing lots of travel, an AED is always great to have. For those advanced, the monitor does 10 times more than what an AED can do, so that's always great. But just for the typical close protection, you're going to have your pressure bandages, you're going to have your tourniquets, scissors plus or minus in them, chest seals, and that's basically what you can do in terms of kind of a personal IFAK to save yourself or to save your buddy. I'm not the one to say that IFAK is only your IFAK and you can't use it on, you're going to use it on whoever you need to use it on, and you hope your buddy has one too. So if you need it, if you used yours on him, you can use his. But and then just Motrin, Tylenol, things like that you're going to use for yourself when you're on an operation and you don't have someone you can go to get those medications. But the IFAK itself is small, right? I mean, if you're not getting shot or stabbed, it's really good for nothing. And then if something medical happens, then you're not going to have the items nor be trained to use them anyway. But for me, I mean, I've got an extensive kit when I do, operations and things. I just worked an Emmys event last night from California here for it's like TV show awards here, and I've got a different kit that I use, and there's 400 plus people in the after party for the show, so it's different.
Yeah. I think it's very important what you just pointed out, that you as a medic or as a doctor, you can do way more. So of course your kit is way bigger, so it would not make sense to give this kit just to have it in the car if you don't have anyone who can actually use it, right?
Yeah, when I first started in this industry 5 years ago, I joined a team, and they had these beautiful IFAKs that they carry. It was just a pull-out IFAK, and it opened up, and they had 14 gauge needles for needle thoracostomy, which is a procedure you do for tension pneumothorax. And we had one PJ on the team, and then the rest, there was a couple paramedics, EMTs, and then everybody else had the same exact kit with all these, needles. Other than the PJ and one of the medics, nobody knew how to do it. Nobody knew what to do it for, how to use the needle and what it was for, the signs, symptoms of what it was for. And I pulled them on my first day working there. I was like, pull them out. Like, you don't have to carry stuff just to carry stuff. Like, what is the purpose of even having that in it's going to cause you a problem. You forget going on a plane and it's got a big needle, that's 3 inches long. Like, it's just going to cause you more problems than good. If you don't know how to use it, just why are you carrying it? It's a waste of space. I think a lot of people just like to carry stuff to carry it so they could say they're carrying it and just don't know how to use it. And it's just, it's not good.
Yeah. I think I see that quite a lot in close protection teams. They sometimes even have a dedicated car where all of the stuff is in the back, like a response car basically, but there's no medic in the team who could actually use it. And then they show all of the stuff, and I'm like, but who can use it? And then they explain me how to theoretically use it. And I said, I theoretically know how to use this needle, for example. I've seen that, I've seen someone using it, but can we actually do it if it happens? And So most of the time, like you also said, we have to say no. It's useless. And then, like you're saying, then
Yeah.
leave the stuff at home or get someone who's trained to actually do the procedure. Then,
It's the feel good baby blanket. You know, everybody feels good carrying all this stuff until you I mean, that's basically what it is.
true,
It's, you know, and you're just like, okay, I don't, I mean, it's a waste of space. You're not going to ever use it. You're never going to know how to use it. And you're going to have to basically hope someone, you know, it's like when you're flying on an airplane and they've got equipment and then they have to hope that there's a medical person on board. Otherwise, you know,
yes,
it's worthless. Yeah.
true,
So,
true, yeah. Okay, cool. So, if someone would like to contact you because they're serious about their medical education, how's the best way to contact you?
yeah, I mean, I think LinkedIn, and I think you'll post the link. So yeah, just if they can just Michael Gerges, MD on LinkedIn, and you can find me and my contact information there. So
Yes. Okay. Of course, I will put your link into the show notes, so whoever would like to contact Michael can do so. So thank you very much, Michael. I think it was
thank
very
you, Inga.
interesting. Yeah, I learned a lot again. So yeah, I hope next time when I'm in the States, I can come visit you. And yeah, I hope to see
Absolutely.
you in person one day.
Absolutely. Thank you, Inga. I appreciate it. And I know we've been connected on LinkedIn for years now, and I know you're busy. Everybody's busy. But yeah,
True.
absolutely. Open invite. When you ever come to sunny Southern California, you come visit.
Okay. Thank you very
Awesome.
much. It was very
Thank you.
nice. See you.
Thank
Bye
you.
bye.
Bye bye.